morning on abnormal uterine bleeding in the non-pregnant patients. So I specified specifically non-pregnant because if you have a pregnant lady that is bleeding, that's a whole different kettle of fish. I also felt for this topic that because it's such a broad topic with different causes that can lead to abnormal uterine bleeding, that I did not include a specific case, just because this is quite a common problem that we see on the UDOC or in our UDOC clinics. So I thought maybe just a general approach to a patient with abnormal uterine bleeding will be a good idea for today. So let's fire away. So before we start talking about the abnormal, let's quickly just have a look at normal menstruation. So normal menstruation, we can divide in two phases. So the first phase is the follicular phase and the second phase is the luteal phase. So the follicular phase usually starts with the first day of the menstrual bleeding. This is usually when the endometrial lining gets shed by the body. So FSH, or follicular stimulating hormone, is the hormone that gets secreted in the brain to stimulate your ovaries to start producing an egg and also to secrete estrogen. So in the follicular phase, estrogen is the main hormone that is involved. Estrogen will also cause your endometrial lining to start thickening and to prepare for a possible fertilized egg to be implanted. And then your luteal hormone, or LH, is the hormone that gets secreted by the pituitary gland in the brain that will then stimulate your ovary to secrete the egg, and ovulation takes place. This is round about day 14 of a cycle. Usually it depends from person to person, but usually around day 14 of the cycle, you will have ovulation, where an egg gets secreted into the fallopian tube. This is where the luteal phase then starts. So the luteal phase, you can see on the diagram on the right hand side, progesterone is the hormone that is specifically involved here. Progesterone gets secreted by the corpus luteum, which is the sac that the egg was in that got secreted now with ovulation, and the corpus luteum will then secrete the progesterone. So during the luteal phase, you will see that you get maturation or even further thickening of your endometrial lining, thickening of your blood vessels, all in preparation for possible implantation of a fertilized egg. By the end of the lifespan of the corpus luteum, when it starts decaying, this is when your progesterone levels start dropping. Usually if there was implantation of an egg, the egg or the yolk sac of the fertilized egg should then start producing or continue producing progesterone. So progesterone is also known as the pregnancy hormone, but because there was no implantation, you get a decrease in the level of your progesterone in the body. And this is basically where your body picks up that there was no implantation, and the uterus then sheds this extra lining, if I can put it like that, of your endometrium. And this is then when your menstruation starts. So according to the World Health Organization, the definition for normal menstruation is a cycle that's anything between 21 and 35 days, and the duration of bleeding is anything between 2 and 7 days, and bleeding happens in regular intervals. Anything outside of this definition is then classified as abnormal uterine bleeding. But before we get to abnormal uterine bleeding, you get different types of abnormal uterine bleeding. So it is also defined as any bleeding from the uterus that's abnormal in volume or regularity, and that is present for most of the time for at least 6 months, which is actually quite a long period of time. Also, I'm just quickly going to briefly touch on some old terminology that has been replaced by newer terminology. So back when I still studied, we used to learn about menorrhagia and metrorrhagia. That has been completely replaced by new terms. So menorrhagia is now known as heavy regular menstruation, and menometrorrhagia we now know as heavy irregular bleeding. Then also they refer to the timing of abnormal uterine bleeding. Is it intermenstrual postcoital, which are both quite self-explanatory. And then you can also classify it as abnormal uterine bleeding, not otherwise specified. So this is a type of abnormal bleeding that where you haven't identified a specific cause or an obvious abnormality in the anatomy that can be the reason for the abnormal bleeding. So the most common causes, I'm just briefly going to touch on. So I haven't included all the causes. There's a very long list of potential causes that can cause abnormal uterine bleeding. There is a nice mnemonic called Palm-Cohen, which just helps us to remember the most common causes and what to look out for or what to think about when we want to diagnose abnormal uterine bleeding. So we can briefly divide it into two major groups, structural and non-structural causes. So structural causes, that's anything where there is abnormality in the anatomy or where there is tissue in a place where it's not supposed to be. So anything that can disrupt the normal anatomy. Here we think of this, so the P stands for polyps, A for adenomyosis, the L for leiomyomas or fibroids, and the M stands for malignancies. So our non-structural causes are all the other things that is not causing a disruption of the normal structure. So the C stands for coagulopathy. So these are all our bleeding tendencies. The O stands for ovulatory problems. E, endometrial problems. The I is for iatrogenic. So that's where we come in as healthcare workers. We give patients certain medications that can make them bleed, implants, intrauterine devices, hormones, etc., that can make them bleed. And the N stands for not otherwise specified or classified. So in our approach to a bleeding patient, we always need to be systematic, starting with a good history, a thorough history, a focused clinical examination, special investigations, and then later we will get to the specific treatment. So what do I need to ask for in my history? So it's always important to take a very detailed menstrual history. So ask the patient, how old was she when she started bleeding for the first time? Has she ever had a normal cycle? Has she noted any change in her bleeding time, in the duration of her cycle? Has she noted any changes in the amount that she's bleeding, that she's bleeding more heavily than normal? Always ask about the last normal menstrual period and about symptoms of pregnancy. Like I mentioned in the beginning, if a patient is pregnant and she is bleeding, then you are dealing most probably either with a miscarriage or some other complication of pregnancy. So it's quite important to exclude pregnancy before you start treating a patient. Also ask your patient, when do they bleed? Is it intermenstrual bleeding, so in between their period? Is it post-coital, so after sexual intercourse that they bleed? Is it associated with any pain? And then also ask about potential infection. So ask about a vaginal discharge, whether it's offensive or not, and take a full gynae history. Was the patient ever pregnant? How many children does she have? Any problems with conception? Was there ever any miscarriages? Any medication that she's using at the moment for contraception? Is she sexually active, and has she ever had a pap smear, and when was that done? Also ask about medications used. This specifically ask about hormones, especially contraception, or if a patient is on hormone replacement therapy, and ask about anticoagulation therapy that the patient might be using. Also ask about a history of bleeding tendencies. So most of the bleeding tendencies, like your von Willebrand's disease or your hemophiliacs, there is a very strong genetic component. So ask about a family history of potential bleeding tendencies. And then you can also ask about any other endocrine system that might be dysfunctional, especially your thyroid. So specific things that we can look out for on our examination. So first of all, we need to do a hemodynamic status of the patient to determine whether the patient is stable or not. So we always do a heart rate and blood pressure. If the heart rate is extremely high, so above 100, or your blood pressure is very low, then you must start thinking that this patient is probably bleeding a bit more than what she anticipated, and she might be going into hemorrhagic shock. Also do a BMI for the patient. The reason why we do a BMI is just because certain conditions like endometrial cancer is more common in our ladies with a higher BMI. Look at the general condition of your patient. Do they look chronically or acutely ill? And then I think something that is also important to look out for is signs of anemia. So I have included, if you look at the right-hand side of the slide, I have included pictures of what we can look out for to clinically determine whether a patient is anemic or not. So you can look at the conjunctiva of the eye. So if you look on the left-hand side of the column, you will see a patient that's not anemic, and on the right-hand side, you will see the anemic side of things. So you can look at the conjunctiva of a patient, the color of the tongue of a patient, the nail and nail beds. So it can either be pale, or you can look for koilonychia, which is like hollowed out nails due to long-standing iron deficiency anemia. And then you can also look at the palms of the hand. If you are unsure, it's always you can always compare the patient's color to your own. Hopefully you are not anemic, but then you should see quite a big difference between yourself and the patient. The reason why I included this is just because this is something that you can do in your clinic, signs that you can look out for in your clinic to determine whether a patient has bled a lot or not. Also, keep an eye out for any bruising or petechiae. Look for purpura. We usually do an abdominal examination to look for masses or if there is any uterine enlargement, and then also associated tenderness. And to be thorough, we can also do a breast and thyroid examination. A speculum examination will be done usually by a doctor, but I don't know in your clinics at the pharmacy whether you can do speculums, but here we will usually look for obvious abnormalities of your cervix and then the vagina, and you can do a bimanual examination to determine whether there is any uterine enlargement, whether there's masses of the ovaries, any tenderness, any specific masses that you can feel. So onto special investigations that we can consider for our patients. So 2 special investigations that you can do in your clinic are urine pregnancy tests and also ward HB. So if you see your ward HB is less than 8, then we will usually do formal blood. So a formal full blood count. And if the patient has a HB of less than 6, this is usually an indication for a blood transfusion. So then it's important to do your blood smear, differential count, and vitamin B12 levels before you transfuse the patient. Because after transfusion, your blood results become distorted, or you actually see the transfused blood's results instead of the patient's bloods. Cross-match will usually be done if a patient needs a transfusion. Then you can consider doing a clotting profile for a patient where you suspect a bleeding tendency. So these are all your ladies who has had extremely heavy bleeding since the start of their periods. You can also consider doing thyroid functions if you've picked up anything abnormal there. And then routinely, we will not really do prolactin levels, just because it's quite an expensive test, and we will only consider doing this if we cannot find any other cause for the bleeding. Also, all ladies that are sexually active need to get a pap smear done unless they've had a normal result within the last year. And if the patient is bleeding quite severely, then we can defer the pap smear for at least 2 weeks. Biopsies can be done if you find anything abnormal, usually on an ultrasound, but I've just included in the lab test that you can do biopsies, but this will usually be done by a specialist. We can also refer our patients for imaging, usually ultrasound, so it can either be a transabdominal ultrasound or a transvaginal ultrasound where we look for fibroids. You can look at the size and position of the fibroids, and also you can look at the endometrial lining. If it is very thickened, especially in our patients over 40 that are obese, hypertensive and diabetic, then we need to exclude endometrial cancer. In our patients that's been on contraceptives for a very long time and you see a very thin endometrial lining, this might make you think of an atrophic endometrium that can sometimes cause spotting or breakthrough bleeding. So let's move on to the treatment of our patients. So first of all, I think it's quite important to determine whether your patient is stable or unstable. I'm going to focus more on the treatment of your stable bleeding patient, where your unstable patient will usually be referred to hospital. So this is your patient that, like I've mentioned in your clinical examination, the patient that's pale, tachycardic, and hypotensive. Usually they might be a bit sweaty. You will see this patient. They will feel unwell, dizzy. Urgently refer them to the emergency department where they will be stabilized and resuscitated. Emergency blood can be started and a further workup should be done for them in hospital. So treatment for your hemodynamically stable patients. So this is usually the type of patient that we will see in our UDOC clinic. So first of all, it's quite important to find the cause and to treat the cause. Always explain to your patient, not just for this specific problem, I think for all diagnoses made, it's quite important to explain to your patient what the diagnosis is, what the further workup is, further plan is, and what the treatment is. I think your adherence or the patient's adherence to medication and understanding in their disease process is also much better if you explain to them nicely. If you have specific structural causes that you've identified, like fibroids or cancers, usually we refer them to specialists for treatment, and sometimes they might even need surgical intervention. And then if you have picked up that the patient has a bleeding tendency or any medical reason for bleeding, then this will be also treated accordingly. But let's talk about the patient that comes to you in the clinic and says, please just make the bleeding stop. Is there anything that we can offer them? So drugs that we can give them to stop the bleeding, usually we have two big ones. It's the progestin and our tranexamic acid. So progestin is Promelot that we give them usually for at least 2 days. So you can give them 5 milligrams 4 hourly until the bleeding stops, but for no longer than 48 hours. This will reduce the bleeding by anything between 95 to 100%. Just warn your patients about the complications of progesterone. So they might have weight gain, oily skin, mood changes, and headaches, or most commonly experienced by patients on the Promelot. Tranexamic acid, we can also add to the progestin. That's 1 gram 6 hourly. We usually give it for no longer than 4 days. This will reduce regular heavy bleeding by up to 50%. It's always important to remember that tranexamic acid will never make an irregular bleed regular, and it's contraindicated in patients with problems with blood clots. So after the bleeding stops, the guidelines actually advise us to start a combined oral contraceptive pill 3 times a day for a week, whereafter we can give it only daily for 3 months. So now we've stopped the bleeding, is there any way that we can help the patient to have a regular cycle again? Yes, we can. Most of the patients react quite well to a combined oral contraceptive pill. We will continue this for at least 6 months, and this will decrease the bleeding by up to 50% and also decrease pain during menstruation. We can also offer them progestin only. So the 2 big groups that we have is the medroxyprogesterone acetate or the norethisterone. You can either offer them the oral or the injectable form. If you use the oral form, usually we advise them to take it from day 5 to day 26 of their cycle, and we usually give this for at least 3 to 6 months. Your non-steroidal anti-inflammatory drugs like Brufen can be used 3 times a day, usually just for the time of bleeding. This can decrease the bleeding by up to 45%. Just remember that it is contraindications in our patients with kidney disease, our asthmatic patients, and also people struggling with peptic ulcers or reflux. And then, like I've mentioned before, tranexamic acid can also be used regularly from days 1 to 4 of the cycle. Other treatment options that we can offer patients is something like your hormonal intrauterine device, like a Mirena. Just a side note, this is not available in our public hospitals, but in private, we can prescribe and administer it to the patient. This is usually a treatment option that we will offer to patients who have extremely heavy uterine bleeding, because it will reduce the bleeding by anything between 95 and 100%. Usually in our patients that are hemophiliacs or that have bleeding tendencies, this is a good option to decrease the bleeding. Just remember that this might initially cause irregular spotting, but the heaviness of the bleeding will be much less. Then, like I've mentioned before, if you do an ultrasound and you see a very thin endometrial lining, especially in our patients that's been on long-term treatment of Depo-Provera or combined oral contraceptives with a very low estrogen dosage, this can cause atrophic endometrial lining that will cause breakthrough bleeding or spotting. For them, we can often offer a conjugated estrogen like Premarin. It's a daily dose for 3 weeks, and this usually sorts out the thin endometrial lining. And then for our patients that are iron deficient, we need to start them on iron supplementation 3 times a day, usually with meals, and also you can add vitamin C just to help with the absorption of your iron. How do we follow up these patients? Once again, it depends on the cause for the irregular bleeding. That will determine what our specific treatment and then also what the follow-up should look like. So some of the structural causes or cancers that will be followed up by specialists as well as oncologists. But if we have started in our UDOC clinic, we started treatment, then follow up within about 3 to 6 months is usually a good idea, just to determine whether the medication that we've prescribed is working. Is the patient okay on the medication that we've prescribed? Is there any specific problems or new problems that they are experiencing that might need further investigation? Thank you. So that's all from me. I hope that you have gotten a better idea of just a broad approach to a patient that is bleeding abnormally. Yeah, you can fire away with any questions if you have questions, and we can try and answer them. So just the references that I've used for this talk.
Great, thank you very much, Dr. Eksteen. Greatly appreciated and also very informative. So yeah, should you guys have any questions, just tap on your screen once and you'll have that option to either raise your hand, or if you wish to chat, you can use the chat function and type in your question. Or, and if you wish to speak, then you can just raise your hand and we'll open up the floor for you. So yeah, guys, we should get everything sorted within the week, and then we'll send out your communications to that you can carry on with the UDOC consultations and such. So just bear with us a little bit longer, but we will get everything up and running again shortly. So yeah, any questions, feel free to ask. Just give it a few more seconds there. And then again, we will be also loading the presentation during the course of the week. It should be up under your app on the iPad that's called recordings, which you can just check out again should you have the need. It looks like some of the guys are starting the clinics also, so dropping off. Then also we will be, while we're giving you some time to think about questions, if there is any, we will be sending out communication as well. You need to log in on your Zoom account. So we will be sending out you login details for the sisters and the clinics. So there's specific login details that you're going to have to use to log into your Zoom account on your UDoc tablet. So going forward, we will need you to do that. And in order to then join these sessions, you will also have to be logged into your Zoom account in order to join the webinars. But that's going forward, but we will assist you in that process as well. Okay, it seems like that people are dropping off and starting the clinic. And there's no questions by the looks of things. So again, thank you very much, Dr. Eksteen. Yeah, thanks everybody for joining, and we'll see you next week.
Thank you. Bye.
Hey, have a good one.